In this video, I'm going to be talking about the role that interventional radiologists play in a trauma patient. So what is interventional radiology? This is essentially a number of techniques which use radiological images in order to provide targeted therapy to certain areas of the body. So this means that it's minimally invasive, and it means that your patient goes through a lot less trauma and there's a lot less bleeding than if you go through a surgical approach in order to try and prevent hemorrhage. But on the other hand, it does require a clear target site, so it requires something like a CT scan to have been done prior to going to the interventional radiologist. And you do have a narrow range of movement, so if something happens with the patient, it may be necessary to still move to surgery if you find that there's a number of other sites of bleeding which you weren't aware of. So in trauma, the main technique used is called transcatheter embolization. And this is where you insert a catheter into the vascular system, typically an artery, and you occlude the vessel by depositing thrombogenic materials such as gel foam slurry or coils. And this means that these bleeding vessels are no longer bleeding because they're occluded. But there are a number of things that you have to consider because you can't just go around blocking up any artery which you want. You have to make sure that the vessel has collateral supply. So that means that there's other vessels which are supplying the area which it supplies blood to. Otherwise, if you block off this artery, then you'll start to cause ischemia and necrosis of these tissues, which will cause more problems in the long term. So this is the process by which a patient goes to IAR and the process that is then performed. So you have a bleeding trauma patient who comes into the hospital, and when you go to a CT scan, they demonstrate a small bleed in one of their arteries, for example. And this may be an internal iliac artery. The patient can then be taken to the interventional radiology suite, and they will clean and prep the groins so they can insert an angiography catheter into the femoral artery. They then will place essentially an X-ray above the area where they're trying to work, so above the pelvis, and they will utilize their catheter to then release dye into this area. And with this live X-ray imaging and the dye, they'll be able to detect all the different areas in which there is bleeding. They then utilize a different catheter which is inserted to the area which has been identified as bleeding. Say it's one of the branches of our internal iliac artery, say our pudendal artery, and they will then deposit the thrombogenic materials into this vessel, and this will cause it to start to occlude and a clot form in it. And this means that there's no longer bleeding distal to this site because they've identified which vessel was bleeding, and they identified that it wouldn't be a problem to block up this artery, so they've blocked it, and then they remove the catheters from the groin and place pressure on the groin. And this prevents bleeding from the site at which they've entered. And then this means that the patient's bleeding has stopped despite the fact that they've had a relatively atraumatic intervention. So at the moment, this is predominantly only done in major trauma centres because you require staff who are trained in interventional radiology, and you require a suite in which you're able to perform interventional radiology because you require the live X-ray imaging and the use of catheters and things like that. So some major trauma centres are now moving towards trying to have joint theatre and IR suites because, as we said, one of the disadvantages of interventional radiology is that once you've begun the procedure, if you identify a problem, then you might still need to move to a surgical approach. But if you're doing this in a typical interventional radiology suite, then you'll still have to travel over to theatre in order to open the patient, which in a time-critical situation may be a problem. So if you have a joint theatre and IR suite, then it might be that you can start off with an interventional procedure, and then move quickly to a laparotomy, for example, if there's a problem. So currently, this is being used predominantly for pelvic or abdominal bleeds, with a small number of target vessels which have been identified on a CT scan. But over time, more and more of these patients are being treated by interventional radiology, which means that there may be a move towards trying to target larger vessels and finding other ways of preventing the bleeding and placing stents and things like that, or moving to preventing bleeding in vessels in other parts of the body, so potentially things like the thorax or the upper or lower limbs. And maybe even moving towards going straight to interventional radiology suites if there's a suspected bleed which will be amenable, rather than having to have a CT scan. And if you think that you need to go straight to an intervention, currently the plan is always to go straight to theatre, whereas there might be a move towards going straight to IR in the future. So IR, some people do say, is one of the main points of the future of intervention treatment of trauma patients.